and welcome to today's Talking Point. My name is Vic Manning. I'm a professor in addictions at Eastern Health Clinical School and Monash University and Head of Research and Workforce Development at Turning Point Eastern Health, and I'll be facilitating today's Talking Point. Maternal Alcohol Reduction Interventions, coproducing support for women to improve health and reduce alcohol harm by Dr Abi Rose. I'd like to begin by acknowledging the traditional owners of the land on which we meet today and pay my respect to their elders past and present. I extend that respect to any Aboriginal or Torres Strait Islander peoples listening today or in the future. We recognise the lived and living experience workforce and all people accessing our services as their expertise, partnership and experiences help us shape services that are safe, accessible and inclusive. So Talking Point is a regular series of publicly available lectures that aim to inspire, inform and challenge our notions of what we know about addiction and its impact across society. We really like our webinars to be as interactive as possible. So for those of you in the room and those of you online, please feel free to ask questions. And for those online, via the Q&A function, and we'll get to those at the end of the presentation. Our webinars are recorded and made later available on the Turning Point website. So now I'd like to introduce Dr Abi Rose. Abi is an experimental psychologist at Liverpool John Moores University, UK. Her research explores girls' and women's alcohol use and well-being, investigating the drivers and consequences of drinking across the life course. Abi works with community groups and public advisors representing a variety of lived experience concerning alcohol use and mental health. Her research informs development of alcohol health policy and evidence-based support which meets the needs of service users. Abi is co-lead of the Substance Use and Addictive Behaviour Group in the University's Institute of Health Research and sits on the committee of the UK's Drug Northwest Network. So please welcome Abi.
Thank you. Thank you very much for coming and inviting me to talk. As Vic says, basically my work is really looking at girls and women's alcohol use over the life course, kind of understanding why girls and women drink at different points. Maybe they're kind of vulnerable to different harms at different stages. So I'm going to talk a little bit about that. So what you can see here is just kind of like the life course, and at different stages we might be susceptible to different types of stigma, certain harms, for example when we're pregnant with fetal alcohol spectrum disorder, and how those kind of harms kind of change over the life course. I'm just going to focus, I don't have time to talk about the whole life course today, so I'm just going to focus on maternal drinking, which will cover pregnancy and motherhood, and also talk a little bit about perimenopause and menopause as well. Those stages are closer than you think. Also, before I really start getting into it, for those of you who don't know Liverpool, if you know UK regional accents, you'll know that I'm not from Liverpool, but I moved there in 2010 and it's a really lovely place to live and work. It's one of the friendliest places on the planet, but it's an interesting place to work as well. So I'm not going to give you a history lesson. However, I'm going to give you a bit of history. Liverpool used to be a very affluent port city, and for various reasons that changed. And in the 50s, 60s, 70s and the 80s, it became much more of a disadvantaged, deprived areas, unemployment rates. And we had a government in power at the time who decided in the 70s and 80s for managed economic decline. So there was soaring unemployment. There was an awful lot of deprivation, health inequalities. And there was also the Hillsborough disaster, which, again, the government at the time and certain newspapers blamed Liverpudlian supporters for. It wasn't their fault at all. And so the Justice for 96 campaign is still, going strong. But the reason why it's kind of important to understand that kind of background is that when we look at Liverpool, so these are kind of the regions of Liverpool, the white is the most affluent and the red is getting kind of like more and more deprived. We understand that there is a lot of advantaged groups in Liverpool and there is an awful lot of disadvantaged groups in Liverpool as well. So we have one of the third most deprived local authorities in the UK, and we have very high levels of alcohol use disorder and alcohol-related harm and mortality. Because Liverpool has this very distinct personality, and it's, Liverpudlians are very, very proud of being from Liverpool. There are these amazing grassroots organisations, so you can really get to work in the community and things. At the same time, there is a real kind of anti-establishment kind of fighting back against authority, which isn't always easy to get funding from kind of like authoritative kind of funders and things, but it's an interesting mix. And what you can see here, the life expectancy picture, so it's a bit difficult to see here, but you've got Mossley Hill here in green, and you've got Sand Hills here in red. So that's only 4 stops on the train. It takes 15 minutes. There's 13 years difference in life expectancy between those 4 stops. So when I talk about there is a lot of advantage and a lot of disadvantage in Liverpool, that kind of helps to show it. So in terms of why we take a gendered approach, so drinking is a gendered behaviour, whether we like it or not. Women tend to drink for different reasons than men, and we tend to drink for different reasons during certain stages of our lives, which I'm going to talk a little bit about today. Also, women tend to receive a lot of stigma about their drinking behaviour, again, especially in specific life stages. So, for example, drinking in pregnancy, women get very stigmatised for that. And also, as women get older, there are these stereotypes of how women should behave when they get older, what they should or shouldn't do. Also importantly, traditionally, there's this big gender gap in the way we drink. So men drink more, there are more men drinking. That gender gap is decreasing. So what this graph here shows is from 1890 down to 2000 at the bottom. And the red line is men's drinking, the blue dots are women's drinking. And what you can see over time is that those blue dots are starting to follow the red line more closely. So we know women are drinking more and they're drinking more like men. This is really problematic because there's something called the risk severity paradox. So the risk severity paradox is that despite the fact that more men drink and more men drink higher levels, women are more vulnerable to harm. So women don't have to be drinking at the same levels of men to be experiencing high levels of harm. So we need to be paying more attention to women's alcohol use as well. Within the UK, we know that rates of alcohol use disorder in women are increasing. We know that 15 to 49 years of age, which is like typical childbearing age and also going into perimenopause, alcohol is one of the leading risk factors for ill health and early mortality. Also, really importantly, this graph here, so this shows Scotland, Northern Ireland, Wales and England. So for the first time, alcohol-specific deaths, the rate of increase in alcohol-specific deaths is increasing higher for women now than for men. That hasn't really happened before, so we need to be paying more attention to it. And also, I think as the evidence grows that it's not just about alcohol use disorder and really severe levels of alcohol consumption that is associated with harm, we're starting to understand more now that moderate alcohol use, grey area drinking is also associated with harm. And this is where a lot of women kind of believe their drinking sits. So actually the evidence is coming out, well, that drinking behaviour is associated with harm, and we need to be getting that message out in a way that's much more consistent and persuasive without adding stigma to women. So that's kind of what I try and do. So if we look at alcohol-exposed pregnancy and potential harm, so I'm not going to go through all this in detail because I'm sure you kind of already know, but in terms of the UK, we have one of the highest rates of alcohol-exposed pregnancy in the world. So the amount that's usually, the prevalence rate that's usually quoted is 41.3%. That's based on quite old data, to be honest, and there is other more recent research when they asked people about alcohol use in pregnancy, around 75% of women said that they had consumed alcohol during pregnancy. We know that alcohol-exposed pregnancy increases risk of harm, even at relatively low to moderate levels of alcohol use. Again, it's not just about binge drinking in pregnancy, which is associated with harm. But we do know that because we have one of the highest rates of alcohol-exposed pregnancy, we do have one of the highest rates of fetal alcohol spectrum disorder in the world as well. So again, a modelled prevalence rate that often gets quoted is 3.2%. If you talk to anybody who works in this area within the UK, if you talk to any clinicians who are working with children with FASD, they will say it's higher than that. And there was a fairly recent study where they screened children and 17% screened positively for FASD. That doesn't mean that 17% of children have FASD. It just means that it would warrant further investigation. So the other thing that the UK government tried to do recently was to cost FASD. So around 2 billion per annum is the cost of FASD. That does not include all the costs of FASD. It doesn't actually include a lot of the health-based costs, so it's much higher than that. But people seeing these sorts of numbers are starting to pay more attention to it. Also, in terms of motherhood is really important. So when I got into this research, I've come from a slightly odd pathway. So I'm an experimental psychologist doing lots of laboratory-based alcohol research, which is very nice and neat. I got people in my lab, I tested them, and then they went on their merry way. And then for various reasons, I changed my entire research career and now just focus on girls and women's alcohol use in a much more applied setting. And people find it odd that I don't just focus on pregnancy because of FASD, but I actually got into this because of maternal drinking after the child had been born. So this is something that's really important. And we have in the UK the Embrace report. So I don't know if you have something like that similar in Australia. So this is a report every couple of years which talks about kind of maternal health care, what are the big risk factors for ill health and mortality and things for mothers. And in the latest one that was published last year, alcohol and other substances was the biggest cause of death in mothers between 6 weeks and 12 months postpartum. So in the previous report, it had been suicide, and those two have flipped places now. So we know that it's really important. There is some research that suggests that alcohol use disorders in mums has a bigger negative impact on children, but honestly, the research is mixed. There's some research that suggests it's dads. I don't think it helps anyone to try and pit mums and dads against each other. Parental alcohol use disorder is it's important. And again, going back to this idea that it's not just about alcohol use disorder, so non-dependent maternal drinking, as hazardous drinking goes up, we see this increased risk of harm in children in terms of all sorts of things, kind of accidental poisoning, accidents, mental health problems and things like that. The other thing that's also important, so this is an Australian study, the graph in the right. And when I was talking at Matilda Centre, they said, this paper, when it was released, this got so much coverage because there's this assumption that I found over and over again in the public and in grant funders and clinicians, everyone, that says, when women get pregnant, they all stop drinking, and then they never really return to drinking again because they're now looking after their child and, they've got maternal responsibilities. This graph shows that that's not the case. So yes, of course, alcohol use goes down a lot in women once they become pregnant, but their drinking trajectory starts to increase again in that first year postpartum, and it pretty quickly goes back to pre-pregnancy drinking levels. So it's not the case that once a woman becomes a mother, that's it, they stop drinking. So I'm interested as a psychologist, I'm really interested in the mechanisms underlying why we drink, but also the reasons why we don't drink, because I think that's important when you're developing interventions and treatments. So we did a survey and we've done qualitative and quantitative work on this. So we had just over 800 pregnant women and almost 600 mums take part. 10% of the pregnant women said that they were drinking after pregnancy recognition. That's important because a lot of alcohol-exposed pregnancy happens before the person realises that they're pregnant. And 3/4 of the mums were drinking. 20% of the mothers were reporting alcohol use in the hazardous or harmful drinking levels, and around 1 in 20 had an alcohol use disorders identification test score, which indicates very probable alcohol use disorder. So in terms of motives to drink, most pregnant drinking was motivated through wanting to socialise and to celebrate, especially special occasions, going to weddings and parties and things like that. They wanted to feel as if they were still able to enjoy things, that they were still a part of things like that. The same kind of things were happening for mums, motives to drinking, but the thing that you see that comes up, 64% of mums were saying that they were so stressed that that's why they were drinking. So they're starting to use alcohol as a way to cope. And then motives not to drink, pregnancy was always to avoid harm to the fetus, to the baby. It was pretty much never about the person themselves. Mums, there were lots more reasons, and they were too tired. A lot of the mums were far too tired to drink, and things like breastfeeding and co-sleeping and weight management. And also you see here that women are starting to say, well, I want to be healthy because I want to be there for my child and things like that. So that's starting to come into play more. And then we also asked people what they felt the barriers were to reducing their alcohol use or adhering to whatever the guidelines are. So in the UK, guidelines are abstinence if you're trying to conceive or if you are pregnant, and then it's up to 14 units a week at any other time. So a unit in the UK is 8 grams of alcohol, but there are specific guidelines around if you're co-sleeping, don't drink. If you're breastfeeding, I'll talk about that in a bit because it's so inconsistent. It's very annoying. So about half of the pregnant women said there weren't any barriers. They could just stop drinking. The biggest issue was health information being inconsistent or incorrect. So pregnant women were going online and finding information that said that they could drink. And that's probably because our guidelines changed in 2016. So people are going onto Google and saying, can I drink when I'm pregnant? And the old guidelines, which obviously were seen by lots more people, are still high up on the list. So that's what they're reading. And in terms of the mums, fewer people said there weren't any barriers. And the big thing here is that motherhood is too stressful. So women are just too stressed to think about not drinking or to reduce their drinking behaviour. And then I also looked at psychologically traumatic birth in mothers. So this is actually the reason why I got into this area. So after I had my own children, I was involved with the UK Birth Trauma Association, and I realised that there were quite a few mums who had been diagnosed with postnatal PTSD and depression who were disclosing the fact that they were using alcohol to cope with those symptoms. And so I went online to find all the amazing evidence that was going to be on this, because obviously it's important. And there wasn't anything. And so that was kind of like the seed that made, all right, I'm done with laboratory-based research. I'm going to move over to applied research. And I found Sally Hunt at Newcastle University in New South Wales had done a study on Australian mums and found that there was a link between psychologically traumatic birth and alcohol. And I contacted her and I said, do you want to do a replication study in the UK? And this is it. So basically we recruited women who self-reported whether they had or they had not had a psychologically traumatic birth experience. So this is completely subjective. If a woman tells you that their birth experience was psychologically traumatic, you believe them. And we looked at their motives for drinking and how much they were drinking. So in both groups of mums, negative reinforcement motives, so coping-based reasons for drinking, predicted alcohol outcome measures in both of the groups. And you would kind of expect that. So if you're drinking in order to manage your stress and to cope, then you're likely to be drinking more. But the interesting thing that we found was that only in the group of mums who had had the psychologically traumatic birth experience, as their children got older, they were more likely to be coping. They were more likely to be using alcohol to cope, and they were more likely to be drinking more. So we need to look into this further. But what I suspect is happening, when women have a psychologically traumatic birth, they often feel intense feelings of guilt about how they brought their child into the world. They're also still incredibly scared that something is going to go wrong with their child and they're going to die. And I think that what might be happening is that fear and guilt feeds into the woman trying to be the best mum possible, and that kind of stereotype of I'm just there for my child, so that's all they think about. But then as the child gets older and maybe that relationship shifts slightly, then there's a delayed risk of that trauma coming back and resulting in women using alcohol to cope. So we need to look into that in more detail. So that was a whistle-stop tour of the kind of like the evidence on maternal drinking. Now, perimenopause, and what I said earlier, people often assume when they're thinking about the life course that perimenopause happens to old women, and it happens, a long, long time after you're pregnant and things like that. That's not true. So what we're finding is that for lots of reasons, women may be having children later on in life. And we have a lot of women in both our maternal alcohol research and our menopause research where they're talking about, well, I wasn't expecting this. I found myself with a 3, 4, 5-year-old child, and now, I'm hot flashing, I can't sleep. I wasn't expecting this to happen. So for anybody who doesn't know, when women kind of like go into their 40s, their sex hormones, so estrogen, progesterone, testosterone, start to decline. But what's really important in perimenopause, they're going all over the place, they're fluctuating. And it's that fluctuation in hormonal activity which is thought to be really important in terms of the negative perimenopausal symptoms. So hot flashes, irritability, self-harm thoughts, stress, anxiety, low libido. I'm perimenopausal, I can't remember all the symptoms, but there are a lot of them, and they're all horrible. So, but when we understand what sex hormones do, it kind of makes sense why some women, not all, but some women and a good proportion of women feel awful during perimenopause. So our sex hormones influence a lot of major regulatory systems in our body to do with mood, sleep, behaviour. There is growing evidence now that alcohol has a reciprocal relationship with sex hormones. So when we drink, estrogen goes up. And there's some evidence, not for all, but some women are quite susceptible to their own menstrual cycle in terms of alcohol use. So when their estrogen levels are high during their menstrual cycle, they might be more likely to drink. So we know that there's this relationship. Also very important, the HPA axis, our stress hormone axis, and our reproductive systems, they talk to each other. So the idea of if our hormones are going all over the place, if our reproductive system is going haywire, that's going to affect our stress response system. We've already talked about the fact that stress is something that is really important when we're talking about women's alcohol use. Biologically speaking as well, it may be that women might put on some fat when they're like getting older. Obviously, alcohol is stored in fat, so when women are drinking, the alcohol stays around for longer. Also, our levels of enzyme activity, the acetaldehyde dehydrogenase, it declines as women get older. So again, when women are drinking, their alcohol levels are getting to a higher amount and it's staying around for longer. And if that's the case, then there's more opportunity for there to be some harm. So again, we wanted to understand kind of like the motives around alcohol use in women who felt they were perimenopausal or menopausal. So this survey wasn't open for that long, but we got a lot of women taking part, and it was a long survey. And these were the people that got to the end and had a really good data set. So it kind of shows you that people are interested in this. So they self-reported their menopause status. The 12% who are unsure, when we looked at their age, they're probably perimenopausal. They've just started to kind of like feel the effects of it. And around 25% were on hormone replacement therapy. So if we look at the audit categories at the top, first of all, we've got 69% were low-risk drinkers. So that sounds good. But, and this is why we have to go back to this gender-based research, is that there's growing evidence that some of the tools we use may not be fit for purpose, or at least how we score them for women. So there was a big sensitivity analysis with the audit in the UK, and it suggested that actually a score of 5 or more in women on the audit is indicative of hazardous or harmful alcohol use. If we recategorise them, we've got just over half were considered hazardous or harmful drinkers. So what we found was what you might expect. So menopause symptoms and also audit score, they were both associated with poorer mental health, so stress, anxiety, depression. They were associated with feeling more lonely and lower levels of well-being, the kind of thing that you would kind of suppose. Also menopause symptoms, that was so the worse experience women were having from their perimenopause, the more likely they were to be using alcohol to cope. So they were more likely to endorse negative reinforcement drinking motives. And when we did some mediation analysis, so the MENQOL was the validated scale of menopause symptoms. There was a direct relationship between MENQOL and audit, but it was mediated by negative reinforcement drinking motives. It wasn't mediated by positive reinforcement motives, so not socializing or celebrating. So what that tells us is that we need to be identifying women who are experiencing perimenopause negatively. And if you go on social media, then there are a lot of women experiencing perimenopause negatively. And we need to identify those women and those women who are also using alcohol to cope, which we know a lot of women are. And we need to be providing them with information and support that is relevant to them. This is just some of the, so whenever we do kind of these surveys, we try and capture some more nuanced information as well. So in the menopause, we asked women, can you tell us any more about your motives to drink? There was a real sense of using alcohol to cope with lots of different things. So definitely perimenopausal symptoms, but also things like their boredom with their lives, increased loneliness. There was also a lot of women talking about the fact they were using alcohol to numb pain, so physical pain. And we don't find that as much with the pregnancy and the mums. But as you're getting older and you might start to feel more pain, women are saying they're using alcohol to manage that pain. And also in this group, which we didn't find so much with pregnancy or mums, is they'll talk about the fact that they're drinking because they like the taste of it, as if it makes them seem more mature and worldly wise. But actually, when you look at the information on taste, what they're often doing is they say something like, oh, I really enjoy the taste of a cold beer on a hot day, or I really enjoy the taste of a red wine with my partner at a romantic meal. I don't think it's really taste. It's what that signifies, that kind of, it's the value that that drink is bringing to that situation. So you might think that it's the taste. Actually, it's all the other stuff that's packed along with it. So I think taste is complicated. And also libido. So sex drive often wanes during perimenopause, and quite a few women were saying that they were drinking in order to be able to still have sex with their partner, which is obviously not something that we want. So we need to be providing women with much, much more support. And then motives not to drink. So women are getting to this age, they're starting to maybe think about their mortality and how they can be as healthy as possible. So a lot of women are going online and trying to find out health-related information. So they start to think about their drinking and reduce their alcohol use because they want to be healthier. That might just be healthier in general, or it might be to do with something specific. So some women talked about the fact that they wanted to reduce their risk of breast cancer, dementia. Some people talked about the fact that despite maybe alcohol originally helping their perimenopause symptoms, they actually found that alcohol made things much worse, especially around sleep and hot flushes and stress and anxiety, so they stopped drinking. The other thing that we found was that some women talked about this kind of process of the changing role that alcohol had. So they would talk about the fact that when they started to feel perimenopausal, they immediately turned to alcohol to get rid of those symptoms or to manage those symptoms. But after a while, they realized that they were drinking so much, they were worried that they were developing an alcohol use disorder, so they reduced or they stopped drinking. And the one thing I would say here, so this is kind of, I'm going to talk a little bit about value in a moment, but in terms of the motives to reduce drinking, it was pretty much always within this umbrella of health and well-being. So this is a real opportunity. This group of women, this age of women, they are really interested in their own well-being. They are really interested in finding out how they can help themselves to be as healthy as possible. So there's a real opportunity to engage with women at this life stage, I think. So when I talk about value, so in terms of theory, there are loads of theories that are relevant to this kind of area. So you've got obviously self-medication hypothesis. You've got things like social identity theory, self-identity theory. A lot of women, again, when you talk about mums and also older women, they'll talk about the fact that they use alcohol to separate themselves from their caregiving responsibility role. They use alcohol to show that they're still fun and they're not over the hill and things like that. So self-identity theory is really important. Learning theory is very important. But the thing that I keep coming back to is value-based decision-making. So this theory basically argues that at any given time, there are multiple outcomes that could happen in any given situation. So on a Monday morning, I could have a cup of tea or I could have a glass of wine. Because it is a Monday morning, because I'm getting my kids to school, because I've got to go to work, because I've just had a rubbish night's sleep, tea is more valuable to me at that given point. So I drink a cup of tea. On Friday at 6 or 5 or 4 or whatever, it might be that things start to shift and I suddenly think, oh, it'll be nice to have a drink. And for all those reasons, oh, and my husband, I can sit down with him, or I'm going out with my friends. There are huge numbers of things kind of increasing and decreasing our value. It's not static, it changes all the time. And the argument is that whether we are implicitly or explicitly aware of that kind of like decision-making process, it's happening. And the thing that we do in any given circumstances is the thing that brings us the most value at that given point. So within that theory, what we need to do is we need to identify what kind of increases and reduces the value of alcohol for people. So things that might reduce the value of alcohol is people saying, well, I'm going to be really heavily stigmatized and people are going to judge me for being a bad mum if I drink. Social services will take my kids away if I drink. I might have a child with FASD. My hot flashes are going to be worse. So you think of all the things that decrease the value and you counter those with all the things that increase the value. Tiredness is on both, because tiredness is something that women say, I have to drink because otherwise I can't sleep. And other women say, I can't drink because I can't sleep. Sleep is a massive thing for women across multiple life stages. So if we understand what those negative and positive value factors are, we can tailor interventions and treatments for different life stages. And then what I would say in terms of potential treatments, we do need to take a life stage approach. We know that people are drinking for different reasons at different points. We need to take that biopsychosocial perspective as well, because there are biological things that are happening in a woman's body at different life stages which change the way we drink, but also the way alcohol affects us. The society that we live in absolutely changes in terms of the influences of alcohol on our behaviour. And the cultural narratives about what alcohol's role should be. So mums, for example, are told, of course you should drink alcohol because you deserve it, it's your time, it's your reward. Whereas mums who are, women who are a bit older, there's things about, of course you should drink alcohol because it shows that you're still independent and, sexy and fun and all that kind of thing. So cultural narratives are really important. A few things I would say that we need to consider is that a lot of people don't recognise their alcohol use as potentially risky, and I'll talk about that in a moment. So we need to be much better around communicating harms across the spectrum of alcohol use. It's not just about alcohol use disorder. There are a lot of women who don't want face-to-face interventions or treatments. They don't feel it's necessary. It's not going to fit in with their lives or their perceptions of themselves. So we need to make sure that we're providing interventions and support without the need of clinical gatekeepers. I found that a lot of women, it doesn't matter how good the support is that they're getting from healthcare providers, they just don't trust them. And that's often to do with trauma in the person's past. For example, they might have had experiences when they were children with social services and things like that, which means they're just never going to trust authority figures. And that goes back to being from Liverpool as well. And also, this is a big thing. So a lot of women say that the information that they are given by professionals is inconsistent. It doesn't match what they're finding online. They find it patronising. They don't want to be told what to do. They want things to be explained to them so they can make their own kind of mind up. And they want to make sure that they don't feel judged or stigmatised at all. So these are kind of potential treatments. So you can go for indicated treatment. So this is where, that somebody might have an alcohol use disorder or is drinking in a way that needs to be changed for their health and well-being. You can have selective, so interventions for kind of potentially at-risk groups. So, for example, women drinking in pregnancy, they're an at-risk group. And you can have universal public health interventions as well. I know, so I'm going to talk for a few minutes about a particular individual-based treatment that we're about to develop. I know some people hate individual-based treatments, and I get it, because they think it's just about, well, you're putting it all on the individual, whereas actually what we need is system-based change. And that's absolutely true. We talk to a lot of mums who say, well, it's great, but the reason why I'm drinking is because my life is just so stressful. I have to go to work, I have to do this, I have to do that. So there has to be system-based treatments. We shouldn't be in a position where life is so stressful for a group of people that they are turning to alcohol and things like that. So that's just a point I wanted to make. Also incorporate lived experience wherever possible. So again, going back to the idea that a lot of women find the information they're given kind of being told what to do, they can be rebellious and they say, well, I'm not going to listen. But if you bring in lived experience, stories and evidence, they're much more likely to engage with that and feel that they're on the same wavelength. So we've got an NIHR grant. So NIHR in the UK is the National Institute of Health Research. And this is going to start when I get back in November. So the aims of this are to co-produce digital and non-digital alcohol interventions for women who are trying to conceive, women who are pregnant, and mums of children up to 5 years of age. So the aim of the intervention is around helping women to adhere to whatever the guideline is, which is relevant for their stage. And this is what we're doing. So it's co-produced. So we are holding lots of what we call living lab or co-production events. And women and stakeholders and partners will come along and they'll talk about what they want the interventions to look like, what do they want the interventions to include, what they want the interventions to look like. That's something that's really important. So we did a lot of public engagement work leading into this grant. So we had lots of workshops where we gave women lots of versions, so like mental health apps, general alcohol apps, and they hated most of them because they said, they look horrible. And what they want is, and then another thing we thought about doing was to package the alcohol intervention into a larger wellbeing app, because we thought it might be more palatable. But actually women turn around and say, well, no, because if I have a wellbeing app, if there's stuff on alcohol on it, I don't look at it. It's really easy to ignore it. I'm going to focus on the other stuff. So actually I want something specifically on alcohol, but you have to make it seem like it's a wellbeing app. That it's kind of like that I don't have a problem with my drinking, but because I'm a good, individual, and I'm responsible and I want to be as healthy as possible, alcohol is one way that I could manage that. So that's what we're going to do. And then because obviously there are issues around health inequalities and the digital divide, once we're developing those digital interventions, we're going to translate some of that content into non-digital resources as well that can go into libraries, GP surgeries, mums and babies cafes and things like that. And we're also going to be including lived experience films. So we're going to interview lots of women, different backgrounds, drinking behaviours. Going to interview them, going to shorten their interview down, and we're going to do like 5-minute films which they can be embedded into the intervention so that women can listen, hear other women's stories and things, so they can feel a part of it and they can see kind of like the benefits of reducing their alcohol use. And then at the end of the year, we're going to do a short acceptability and usability of the interventions. Part of it as well is we're also going to be co-developing some training resources with it, so that the idea is that the digital intervention, midwives will be able to give it antenatal appointments and things like that. But the way in which healthcare professionals introduce the intervention and talk about it, they need some training on how to do that to make the woman feel like you're not being told that they have a drink problem. So that's what we're doing. And then in terms of ongoing research, I've got a couple of amazing PhD students. So one is researching women's experience of alcohol recovery, and one's looking at women's alcohol use during menopause. They're both doing some longitudinal work, and they're also doing some really nice qualitative work. So this one is just from the women in recovery. So they're given lots and lots of creative materials, and they're asked, create something that represents recovery for you. Doesn't matter what it is, what it does. And then afterwards, there's a long interview where the woman talks about the picture that they've created and how it kind of expresses, how it kind of represents their recovery journey. So that's really nice. And the women's alcohol use in menopause is looking at photo elicitation. So women asked to take some photos during a week to represent alcohol's changing role in their lives, and then they're coming back. So one woman, for example, did a picture of a beer called Delirium. I don't know if you have that. It's got an elephant. It's a very strong beer. And she talks about the fact that she wasn't allowed to drink that when she had children, young children, but now she's older, that's where she can get to and things like that. So it's kind of like, it's looking at that kind of thing. So that's kind of what we're doing next. And we're hoping that all these sorts of things feed into these interventions. So it should become like it's not something that we have all the answers already. It's like just an ongoing intervention that will be developed. That's it. Thank you. I mainly want to thank all the women, hundreds and hundreds of women who have taken part in this research. It takes a long time, so I really appreciate it, because they're all very busy, and my PhD students and my collaborators. So thank you very much.
Thank you, Abi. That was fascinating talk, and you've got such great insights on, these two key populations. My initial thought was women really do get the short straw, don't they? But, the consideration of everything that's happening in hormones and stress levels and changing roles and identity at those key stages, it's amazing there's actually been so little research. And so, just a couple of studies. And so it's really great that you're focusing on this area.
I was upset when I I thought, well, this will, there'll be loads on this, and there really isn't. So we can change it.
We had a question come in around the percentage of women who would, you mentioned, I think in your slide, 10% continue drinking knowing they were pregnant. Do you have a sense of how many were drinking not knowing that they were pregnant, so they look back?
Yeah, so the 41.3% is always about, it's like total, so 41.3% of women. But as I said, that's on kind of like quite old data. So it's much more like the 75%. are likely. And there are a couple of reports that show that once a person realises they're pregnant, then it goes down to around 10 to 15% of women continue to drink. That doesn't mean that they're binge drinking. They might just be occasionally drinking, but yeah, post-recognition.
There's a question about your app. Will it be available worldwide, or the digital platform?
So if anybody's interested in doing any collaboration, so at the moment it's going to be UK based in terms of like the information, some of the information that we give, but that's why I made it a public health intervention. So I made clear when I was designing the grant application that I never wanted you to have to pay for it. I want anybody to be able to use it. I want people not to have to get it from their midwife. They can download it whenever they want. So I think that there would be certainly chances to kind of collaborate with somebody in other countries and just to kind of, tailor some of the details so it's relevant to populations.
Yeah, I mean, that was one of my thoughts, is how do we get this into the hands of, say, midwives or GPs, and particularly this population. It's a bit different, I guess, once, they're middle to older age women who are accessing services like breast screening services. Will be doing the Health for Her, targeting that population, that intervention. But what about the sort of slightly more perimenopausal sort of 40s? Where do we find them?
Yeah, so I don't know what happens in Australia. So a big thing that happened in the UK that, again, it amazes me that it took so long. So 2022 was the publication of the first women's health strategy for England. So we're getting there. But they realised that perimenopause was one of the really big things. So I did something very scientific. I did Control Alt and F, and I looked to see how many times certain words were coming up. So perimenopause, I think, came up over 100 times. Mental health came up around maybe 50 times. Alcohol came up around 20 times. And they were making the link between mental health and alcohol, and they were making the link between perimenopause and mental health. They weren't making the link between all three things. So I think that there is a lot of work to do, but because of that women's health strategy for England, they're now setting up what's called women health hubs in all regions of the UK. So it should be a one-stop shop for people to go and get health. So yeah, we'll be putting stuff in there as well.
Yeah, excellent. We need that here. There's a question around recommendations for those working with First Nation women in Australia who have a high rate of FASD children.
In what sense?
So I guess any recommendations around changing.
So this
stages.
So this is tricky, because I was talking to some people at Matilda Centre about this, because one of the things we always struggle with in the UK as well is we get a lot of diversity in terms of socioeconomic diversity. We get lots of really affluent middle class women getting involved, and women from much more disadvantaged areas. And we also get quite a lot of diversity in terms of sexuality. Ethnicity is one where we're really bad with. And when we've tried to kind of contact and connect with organisations, which I completely understand where they're coming from, they say one of two things. One is, this isn't an issue in our community. There are issues, though, in marginalised, ethnic groups, but it is more hidden. And also they say, well, if anyone's going to do this research, we want to do it. And I completely get it. And when I spoke to people at the Matilda Centre, they kind of said something perhaps similar, that with First Nation, there was this sense that it needs to come from them. So I don't have, I wish I did, but I don't have a magic thing about what you can do to engage marginalised populations more.
But is the intention that the digital or the non-digital intervention will be able to be tailored to different health inequity groups?
Yeah, it will be. So partly that is to do with getting both digital and non-digital resources, but within the digital resource. So what we thought about, so as I said, we did a lot of public engagement work, and we had certain workshops where there were lots of women there, and there were obviously women from more affluent and less affluent areas. And when we were talking about what they wanted to be in the intervention, the more middle class women talked a lot more about self-care and wanting it to feel like it was positive for their well-being, that they were doing something for themselves. And then they would talk a lot about mindfulness and breathing exercises. It was very nice. And I could see the women that were not from the middle class backgrounds rolling their eyes, swearing, and just like, Jesus Christ, this isn't going to work. So what we're hoping to do with the intervention is to have kind of more of a toolbox. Mm-hmm. So there'll be lots of therapeutic components. And when somebody downloads it, they can pick and choose what they want. So they can so it's tailored to maternal populations, but then the individual can tailor it even more to exactly what they want. And what will happen is, as people progress through different stages from preconception, hopefully, to pregnancy, different stages of pregnancy, and then motherhood, the information and the types of things that they are kind of given in the app will change as well. So, for instance, one of the things that women hated was with the general alcohol app was the behavioural substitution. A lot of them said things like, take up running. The others are like, you can't tell an 8-month woman or somebody who's just had a baby to take up running and things. So that's also why co-production is really, really important, because you find what is relevant to them in their lives, what fits their needs and circumstances. So you make sure that the app includes that.
Yeah. That's great. We have a question here around whether there's evidence that links specific traumas to vulnerability to alcohol use in that menopause phase.
I don't know about specific trauma. We do a lot of work with women who are older in that area, and the one that tends to come up more often is around things like domestic violence. So it tends to be male on female kind of trauma, either domestic violence, sexual assault, and things like that. But there's evidence that shows that that's a risk, but I don't think it's particularly around perimenopausal stages.
Okay, there's a few more questions coming in, which is great. So we have Naomi, who's a midwife, and she's asking what tools UK midwives use to screen for alcohol use in pregnancy, and what suggestions they make about reducing or ceasing.
Okay, so this is something that shocked me as well, and this is where I come from. Experimental, everything's very structured and consistent. And we work with the Liverpool Women's Hospital, so this is a big women's only hospital, and all the midwives work there. So I got to know quite a few of them. I was saying, okay, so what questions do you ask? What's it like at the antenatal appointments? And so I was sent a screenshot. It was basically, do you drink? How many units do you drink? Do you want some support? That was it. And nobody understands what a unit is. Nobody ever answers truthfully when they're asked, how many units do you drink? So it's very limited. And then I also found out that different regions use completely different pathways and questions. So it's not consistent at all. So when I've talked to midwives, they tend to say that they go more on their gut instinct and if there are issues. But this is one of the big problems, and this is one of the reasons why we actually want to develop interventions, so that it kind of provides midwives with more tools. Because when we talk to midwives, they say they don't have time to talk about alcohol. They've usually got about 10 or 15 minutes, and they have to talk about diet, smoking, alcohol, domestic violence. And it's just like, we're just going along a tick box. They're also very conscious that they are trying to establish a relationship with the woman. So they find that when they bring alcohol up, it can get women's backs up. And so they don't feel that they have the time to establish that. And also midwives, quite a lot of the midwives have this feeling that things like smoking is more harmful than alcohol. And we need to change that perception. So a lot of midwives will say, well, I give the, abstinence is best. But actually, a lot of women, we say, no, my midwife told me that if I was really stressed, I should have a drink because alcohol is better than cortisol and things like that. So it's complicated.
Yeah. There's a question around whether women continue to drink regardless of the information being shared with them about the harm and risk to them and their unborn child, and how that's best addressed. Does it become a child safety issue? I can imagine this would be quite difficult to manage and would cause distrust on the maternal side of this matrix, as you just said, If a person has FASD, will they have a high risk of developing AUD themselves?
There is evidence that children with FASD are at increased risk. It's interesting though, because there are a number of reasons why they may have an increased risk of developing alcohol problems. But actually, we've been doing some research on, I don't know again if this is a thing in Australia, so we're getting more and more lower strength alcohol products in the UK, and it's being touted as kind of like a UK harm reduction strategy, because if you're drinking low levels of alcohol, it's going to be less harmful. And I was consulted as well with the National Organisation of FASD about this, because there are particular groups who might be vulnerable to this. So pregnant women is one, because if they think that that type of alcohol is less harmful, they might be more likely to drink when usually they'd be abstinent. The other one is things like people with FASD. They find the guidelines incredibly complicated. So if you show people with FASD the different types of alcohol, they'll say 0.05, that's an alcoholic drink. 0, that's a non-alcoholic drink. They find it difficult to see that there's a difference between the small. So there's elements about, kind of communication and misunderstanding guidelines and things as well that feeds into it.
Do we have any questions in the room? There's a question here about recommendations on the best resources for the clinical guidelines. So in Australia, we have the National Health and Medical Research Council guidelines around risk, sort of short-term and long-term, single occasion and longer-term risk. I think was that 2021 that was revised a couple of years ago. It was brought down in terms of the number of standard drinks. I'm not sure if there's specific resources. I'm sure there are specific resources for pregnant women.
There are in the UK in terms of I say there are, but it's tricky, because when the guidelines change from it's abstinence when you're trying to conceive or when you are pregnant, if you then try and backtrack and say, oh, but a little bit is probably okay, this is where women come in and say, what you're telling me is completely inconsistent, and it doesn't fit, and what are you actually saying? And it is hard, because when the evidence shows there is no safe level of alcohol use, but absolutely, as you drink more and more, the risk increases. But kind of trying to explain that is very different. And again, midwives really struggle with it often. You've also got to fight the what's called like social transmission of messages, which a lot of women will come in and say, but I had a kid before 2016, and I was told I could have a couple of units a few times a week, and my parent, my mum drank and I'm all right, and things like that. So there are a lot of kind of like fires you have to put out to get people on board, and you have to just explain very clearly that evidence has moved on. And you can kind of sometimes use the smoking analogy, because actually people accept that much more quickly and say, well, people were told that smoking was good for you, but you don't think it is anymore, and this is the kind of way we're going now. So there are ways around it, but it's not easy. Yeah, and definitely for pregnancy, it would be our guidelines here would be recommending zero consumption. Any other questions? Let's see if there's any more come in. I have a question. Yes, please go. Do you have recommendations around breastfeeding? Do you have specific guidelines around breastfeeding and alcohol use? I mean, I think don't quote me on this, but I'm pretty sure the guidelines would be 0. Right, okay. Anybody in the room know, or anybody online know the answer to that?
Now in New Zealand, 10, 15 years ago, it was a matter of best to not drink, but if you do drink, then there was, about dumping the milk for a certain time, and then or pumping first. So you've got clean stuff for the kid, and then you dump the rest for it. It's really, really complicated stuff. I mean, it's a very dedicated drinker, that follows that properly. Yeah, see, this is one of the most inconsistent and complicated things in the UK as well. And that pump and dump, it's like, no, it's not. If there's alcohol in your blood, there's alcohol in the breast milk. Pumping and dumping does nothing apart from it stops you getting mastitis if you've been drinking a lot. But it's really complicated, and there's low levels of
breastfeeding rates in the UK, especially places like Liverpool. So there's always this kind of attempt to get breastfeeding rates to go up. So they try and remove barriers, and one of them is you can drink when you're breastfeeding. And there are people on breastfeeding forums say that the saying is, as long as you're not so drunk that you've forgotten you've got a baby, you can feed. And so that's something that we've got to kind of deal with in the intervention, around getting some more evidence-based, but non-judgmental information about that as well. I just wondered if you had any.
Well, apparently there's the Australian Breastfeeding Association that would have recommendations, so we'll have to check those out. But somebody's also said that they say if you can drive, you can feed now.
Okay.
So exactly what you were just saying.
Well, yeah.
Okay. We'll have to look into those resources here. Thank you so much. Please join me in thanking Abi. Great talk.